And this is the sort of usual disclaimer, which prompts me to also express my gratitude to Aspen Pharmacare for setting this up and inviting me to speak to you. A great pleasure. It's a topic that I have been thinking about in various ways and from different angles for more years than I care to admit. But anyhow, here we are, and thanks to Aspen for letting it happen. Next, please. Now, the disclosures I have are quite limited these days. I'm gradually shedding pharmaceutical companies that I advise, but we're left with a hard core there. Next, please. And I'm going to offer a caveat here, which is that Aspen, like any sponsoring company in this situation, has to be very particular, as you know, about what is and is not said about its products in relation to formularies, licensing, etc. I'm actually going to give myself a bit more license here. These opinions I'm going to give are entirely those of me, by the way, but they're based partly around the relevant guidelines, mainly international and some national ones. But I'm going to go outside those as well when I think we can look forward better by doing that. So I'm trying to give an idea of where we might be going as well as where we are now. Next, please. So just to give you a little snapshot of what CKD is all about, and the nephrologists here will be very familiar with this, but some of those of you who don't spend a lot of time looking after CKD patients, it's not a bad little take on this. So what have we got at the top there? CKD. Well, we know that phosphate retention and a failure to activate vitamin D to make calcitriol are central drivers to part of the bone scenario that evolves and to the secondary hyperparathyroidism. So those are fundamental, and a lot of the treatment of what we have hitherto called renal osteodystrophy centers around trying to control phosphate and to replace the deficient calcitriol with active vitamin D compounds. So nothing particularly exciting there. Now, there's also, though, an internal milieu in the patient who has reduced renal function that compromises bone cell functions, particularly bone-forming cells, the osteoblast-like cells, that favors soft tissue calcification. We've got a calcifying environment with a lot of soft tissue calcification where we don't want it. It's an environment that stiffens arteries, and it's an environment that promotes sarcopenia as well. Now, these are all bad things to be happening. These are part of the aging process, as we all know, and which is substantially accelerated in patients who've got CKD. And that's really a very dangerous scenario that we're dealing with, and in summary, it probably accounts for most of the accelerated mortality we see in these patients. So we end up with a patient with a poor quality skeleton and likely to have a relatively short life expectancy as well. And the mortality comes mostly from cardiovascular disease. Next, please. So when we're trying to approach the idea, the notion of what are we going to do, we need to know why we're trying to do it and what we want to achieve by doing this. Now, in the renal world, we basically have been very focused on surrogate measures on the left, listed on the left-hand side. These are the usual suspects, I would call them, the biochemical ones, very numerical. Nephrologists, I think, quite like numbers historically, and other ones down bottom left, bone density, bone histology, measures of vascular calcification, and pulse wave velocity. So those are some of the surrogates that we can measure fairly easily, and we can assess the response of those surrogates to various therapies. So that's that. Now, the patients, of course, by and large, are not remotely interested in the surrogates. They want to know about outcomes, and they want to know about cardiovascular events. They want to know about mortality. Am I going to live or die? They want to know if they're going to break a bone or not. And they are quite interested to know whether or not some surgeon is going to come at them with a sharp knife and open their neck and do a parathyroidectomy. These are things that patients are much more likely to be thinking about. But they're also things that are historically we focused on much less. Quite a few of these have been put in the too difficult box, and they are genuinely much harder to measure. And it's been much, much harder to demonstrate benefits of therapies in terms of outcomes than it has been in terms of surrogate markers. Next, please. As far as fracture is concerned, here we are on an outcome that really matters to patients. This is hip fracture in relation to level of renal function. And we see the usual age-related increase in fracture rate. So you can see normals are in black. That's the lowest of the family of lines. And then with each decrement to the level of GFR, there's a substantial increase in the risk of fracture at all ages. And it goes up very steeply indeed, as you can see. So this is a big, big factor. Lots and lots of fractures. And these are hip fractures, of course, which are the most serious ones potentially for these patients. So this has been shown over and over again. This is very much the world we're living in here. Let's have the next slide, please. And this shows the consequence of having a hip fracture if you are a dialysis patient. Now, these data come from 2004, but nothing much has changed, I'm sorry to say. And what you can see here with the blue line is the steady year-by-year attrition survival rate. Note that after 2 to 3 years, survival is still only down to about 50% already, nearly all cardiovascular. So that's a pretty unpleasant line to be on. Even worse, if you break your hip, then you're on the dotted line, and there's a steep drop right at the beginning, which reflects hospital admission, complications, etc., etc. And the patients who've had a hip fracture fare very badly, with more than 50% dead after a year. And that steep drop is something that we have, all of us who look after these patients, seen with some dismay. An elderly person comes in on dialysis with a hip fracture, and we can tell very quickly, more or less from the end of the day, that this poor soul is not going to do well and has a very high probability of not making it out of hospital. And this is a pretty grim scenario for all concerned. Next slide, please. If we look at the same sort of question, this time looking at the effect of fracture on survival by region. So this is from the DOPS study. And you can see that if we look, for example, at Europe, Australia, New Zealand, that's the orange lines. The survival for those without fractures is given at the top, continuous orange line, and then the dotted line much lower down showing survival if you've had a fracture. Massive, great difference. In the USA, the green lines, exactly the same scenario. Surprisingly, if you look at Japan, there's much less difference between those with and without fractures. And that's something that's puzzled me and many others. And I don't think I've seen a convincing explanation for why that should be. But by and large, and likely to be the case in your population, a fracture is going to mark the card and have a profound impact on survival in your dialysis patients. Next one, please. Now, if we look at it in this way, looking now at morbidity rather than survival. So let's look at the slide on the figure on the left, first of all. Now, shown in the red line is the increase in dependence depicted in response to normal aging. And it rises steadily. It's fairly flat, of course, until you're 60 or 70, and then it rises steadily as you get older and very steeply when you get into your 80s and 90s. And superimposed on that, we have the effect of various fractures. So forearm fracture, relatively minor and transient increase in dependence, and then progressively more severe and more prolonged increase in dependence with other fractures, especially if they happen at an older age. So hip fracture at older age has a profound effect on dependence that the person will probably never recover from completely. Now, if we look at the renal scenario, and again, I've just depicted here a qualitative rather than quantitative increase in dependency in the renal patient compared with the non-renal patient. And I simply just magnified this increase in dependency all the way along there. And so fractures, when you have renal disease, are even worse than they are in patients without renal disease. And they're bad enough at that stage as well. Next slide, please. So to just summarize that, bone mineral density, which we're going to come to in a minute, is in the non-renal population, as we know, is a pretty good indicator of fracture risk. It's the most frequently used one, and it's a central plank of what we do. And it's equally good in early stages of CKD 2 and 3. It's reasonably good in CKD 4 and 5, and still well worth doing at those levels. Once you're on dialysis, it gets a little less reliable, and following transplantation, it's also quite unreliable, depending a lot on how long the patient with the transplant had been on dialysis before then. And the reason for that is likely that the dialysis period of treatment really deranges the skeleton in quite a big way, and therefore that hangs over after transplantation. On to the next slide, please. Now, biochemical markers, I'm going to talk about very little here. Now, I know that you bone doctors focus heavily on biochemical markers. In renal medicine, we have done so much less, probably too little. But one of the reasons is that they are confounded to a degree by changes of GFR. So I've said handle with care in the CKD patient. So the formation markers you're all familiar with, listed on the left there. And the first two are profoundly influenced by the level of GFR. This makes interpretation difficult, if not impossible. Total alkaline phosphatase and bone alkaline phosphatase are fine. PTH, provided you know what assay you're using, can be useful as well. The resorption markers are a mixed bag also, but interestingly, the renal community has never really embraced bone markers in the clinical arena. I think we're probably behind the curve there. Next slide, please. So to summarize all that, with advanced CKD, patients, fractures in these patients are less well predicted by the usual tools. They're more frequent and they're much more dangerous. So this is not a good scenario. If we can impact this favorably, that would be a very good thing indeed. Next slide, please. So why do you think it is that bone density measurement, which is the central plank of assessing fracture risk in the general population, is so poor in advanced CKD? And I think this slide summarizes the dilemma we have here. So bone mineral density, of course, by DEXA measures density, measures the amount of bone there on the right-hand side, so peak bone mass and amount of bone loss being the inputs to that. And that's obviously a major determinant of bone strength. BMD, of course, doesn't measure bone quality in any way at all. And to get at that's much harder. That is determined by things on the left-hand side: composition, architecture, turnover, repair, micro damage, etc. And because that's essentially it's a big black hole, when we do a bone density measurement on the renal patient, at least half of the deficiency in the skeleton is not assessed at all. And the result of that is that because we're only assessing one major plank of bone strength, and we lose the rest, and the quality is intensely variable in the renal patient, with huge variations in turnover, much greater than in the general population. So I think this is why the BMD measurement is confounded in the renal patients much more than in the general population. Let's have the next slide, please. And this attempts to expand on that a little more. So what we've got here depicted in the three boxes across the middle of this slide is bone. We have normal bone turnover in the middle, low turnover bone on the left, and high turnover on the right. And broadly speaking, in the renal population, those categories correlate with the prevailing parathyroid hormone level. The higher the PTH, the more likely you are to have high bone turnover, and vice versa. And if you go low, you're likely to end up with adynamic bone disease. If you go high, you'll end up with osteoitis fibrosa. Now that's bad, both are bad for the skeleton with a high fracture rate, but both, as shown down at the bottom, are associated with increased vascular calcification, more cardiovascular disease, higher mortality. So for reasons to do with fracture risk and to do with cardiovascular risk, we want to keep bone turnover somewhere in that middle zone. And we can do that up to a point by manipulating the PTH. And we've got various tools to do that with, of course, which are very familiar to the nephrologist, but they, broadly speaking, consist of controlling phosphate, regulating the amount of calcium coming into the system, either by dialysis or diet, and administering active vitamin D compounds and calcimimetics. And with those options, we can essentially, we have the levers to move PTH more or less where we want to. And most patients, it is possible to get the PTH into that zone. Now, you may have noticed also that the target PTH that sits comfortably with normal bone turnover is 150 to 600 picograms per ml. This is defined by KDIGO, which is an international body, for those of you who aren't nephrologists, that looks at and produces guidelines of a generally good quality. Now you may think, well, why on earth is the PTH that high? And this is for the non-nephrologists here. And the reason is that the uremic skeleton has profound resistance to PTH. And if we let PTH go down to physiological levels, as in normals, we almost always end up with low bone turnover. So we deliberately try and set the pH at this level moderately elevated, but not grossly so. So that's basically what we're trying to do with these patients. Next one, please. And hyperparathyroidism is obviously a big part of that, trying to regulate that bone turnover. And we've got these three ways of tackling hyperparathyroidism: removing parathyroid tissue with surgically, giving active vitamin D compounds, or giving a calcimimetic. And these don't all work in exactly the same way and have different consequences for the skeleton and different clinical consequences. One of the things that happens quite frequently is if we give too much vitamin D, or if we take out the parathyroids and end up with very low PTH, we end up with adynamic bone disease. So if we've done that sort of procedure to treat severe hyperpara, we're basically out of the frying pan into the fire with not enough PTH, and that's in some ways is a more intractable scenario than having too much PTH. But once PTH is gone, there's not a lot we can do about that other than give PTH back, which is a major undertaking in these patients, incredibly expensive, of course. Next slide, please. Now, the concern about the different treatments for high PTH is partly informed by this. Now, the graph on the top of this slide depicts the scenario in a patient with renal hyperparathyroidism, sustained elevation of PTH, and we know that that is highly catabolic for the skeleton and will lower bone mineral density. We also know from the normal population, given teriparatide, a therapy which generates intermittent increases in PTH, that's anabolic. So we have these opposing effects of PTH depending on the background, the level of increase, and more particularly the profile of increase as well. And that's something that potentially could be exploited in some of these renal patients. Next slide, please. And it can be exploited because of this. Now, on this slide, it's a bit busy. I'm not going to go through the whole thing with you, but some of it. I'm just going to draw your attention to the elliptical green points on those figures, which depict the calcium sensing receptor, which, as you know, is widely located all over the body, but I'm going to talk particularly about the receptor in the parathyroid glands and in bone. So let's look at the top box first of all. So this is chronic kidney disease, severe hyperparathyroidism. So we have the calcium sensing receptor being stimulated, and we have parathyroid hormone pouring out of those glands. I say the calcium sensing receptor being stimulated, it's actually, there's insufficient calcium there, so the calcium sensing receptor is downregulated, stimulates PTH release, which has an effect on various target organs via the parathyroid hormone receptor sitting there on the bone on the upper square still on the right-hand side, and has various effects on bone, including, as I showed you before, that sustained catabolic effect. Not a good scenario. Now, if we come along and tackle that, bottom left, with either a vitamin D compound like alpha calcidol or a parathyroidectomy, we basically remove the impact or lessen the impact of the calcium sensing receptor on the parathyroid glands, and in the case of surgery, only on the parathyroid glands, not anywhere else in the body. In contrast to that, if we give a calcimimetic, we decrease the influence, we activate the calcium sensing receptor in all tissues, parathyroid and bone, thereby reducing PTH just like a parathyroidectomy would, but also stimulating the calcium sensing receptor in bone. And there's a body of evidence that indicates that if we do that, we tend to increase bone turnover. And the likelihood is, and there's some experimental evidence for this, that if we treat hyperpara with a calcimimetic, we protect bone turnover better than if we do a parathyroidectomy. So there's, for various reasons, the calcimimetics are preferred in that situation if possible. Next slide, please. Does this have any effect on outcomes? Well, a study that we did way back in 2005, we basically did a post hoc analysis of the data from the Amgen phase 2 and phase 3 trials that were being conducted then, the big studies these, during the early days of cinacalcet. And we looked at the relative risk in the cinacalcet treated patients versus the placebo treated patients of parathyroidectomy, which decreased enormously, tenfold reduction in parathyroidectomy approximately, and also about a 50% reduction in fracture rate in the cinacalcet treated patients. Now, our initial reaction here was, well, this is fantastic, very exciting stuff. Amgen was jumping up and down with excitement, and a lot of us were. So we then moved on to do a much bigger study to specifically looking at this as well as other things. Next slide, please. And this study was called the EVOLVE study, and it was bankrolled by Amgen. This was a very ambitious study, and it was placebo-controlled in dialysis patients, looking at various important outcomes. I'm just going to show you the fracture data here. And you can see that although there is a slight reduction in fracture risk and fracture rate here, it's not great, much, much less than we saw. And there are various possible explanations for that. Very disappointing result, of course, but they include various things to do with the study design. Maybe our study, which was, say, post hoc analysis, and therefore is not as robust as this. It remains to be seen. Amgen has not revisited this one, understandably so. I think they see it as a low yield effort and a very expensive one at that. So there may be an effect on fracture, is the bottom line with calcimimetics, but it's not very great. Next slide, please. Now, what does cinacalcet do to the bone itself? There's only one good study here, and that was done by Bechet and colleagues. Again, a little while back, 2015 published. And this was a study that was the only good one because it was a significant size, 146 patients, and it was biopsy controlled. So they had pre and post-treatment bone biopsies, which is quite an undertaking. Not everybody wants to have a bone biopsy. So 146 patients screened, and 36 dropped out at that stage. So we ended up with 110 started, and this was a within patient control study. Next slide, please. So in the patients with severe hyperparathyroidism, of whom there were 13, the lines depict the direction of travel of their bone disease. So the horizontal line at the top is to severe hyperpara persisting, and then decreasing levels of hyperparathyroidism as you go down that list. And you can see that most of these patients got better, at least to a degree. The green color is depicting a beneficial response before and after the period of exposure to cinacalcet. This is a 1-year study, by the way. So things moving in the right direction there, and no adynamic bone disease or osteomalacia as a complication. So no evidence of an overshoot there. That's very encouraging. Next slide, please. And in patients with mild hyperparathyroidism, slightly more mixed picture. One moved to more severe disease. About half of them remained roughly unchanged with mild hyperparathyroidism, and then significant numbers moved to normal bone histology and to mixed osteodystrophy, and only 3 to the undesirable low turnover scenarios, adynamic and osteomalacia. So histologically speaking, the bottom line here is that this treatment is tending to move most patients in the right direction, but not all. So it's not quite perfect here. Next slide, please. Now, what about some of the drugs we use here? So, as you know, a lot of the anti-resorptive drugs are typically given for 4, 5, 6 years or so. I take some comfort from this slide from Ian Reid, looking at the BMD response of short and long-term osteoporosis treatment with anti-resorptives. Now, these are normals, not renal patients. And you can see that with denosumab in particular, the BMD response is continuing right up to 10 years and potentially beyond. So this is a good deal longer than most patients end up getting that drug, but looking as though it's potentially good right the way through there. Next slide, please. So what about denosumab in patients with low GFR? So the FREEDOM study is the definitive piece of work here. And this study basically used a statistical tool as subgroup interaction to see whether or not GFR had any effect on the response to denosumab treatment. This was a big randomized study, but like a lot of osteoporosis studies, it had a restricted range of GFR for enrollment. In other words, patients with severe renal disease were not enrolled at all, but quite a few had, as it were, the tail slip through, and a significant number of patients, and enough to analyze, had CKD stage 3 and 4, as well as the majority with good renal function. And basically, this study showed that a fracture risk reduction was seen in BMD at all sites, and that the treatment efficacy was not affected by the level of renal function. Very encouraging. And in fact, similar analyses done on the big bisphosphonate studies have shown a broadly similar picture as well. So these drugs generally do work down to relatively low levels of GFR. Next slide, please. And this shows the diagrammatically the response of bone mineral density in that FREEDOM study. And these studies are going out as far as 10 years, as you can see, and looking at denosumab treatment in patients with normal renal function and CKD stage 2, 3A, and 3B. And they're all about the same. I think you'll agree. Those lines are pretty close to each other. So really not a great impact of falling GFR on the response to denosumab in those studies. Again, going out for a full 10 years or so, which is quite encouraging. Next one, please. So the next thing then is fracture. Here, if we look at the, let me get this right here, mild to moderate kidney disease, looking at the same study, the FREEDOM study here, on the left hand, let's just run along the top there, let's leave the bottom alone, run along the top there. The placebo patients, you can see what's happening there in years 1 to 3 at different levels of GFR. So the color codes GFR, green is normal, gray is 3B. And then with denosumab given for 3 years, there's a moderate reduction in fracture rate. Given long term, a big reduction in fracture rate, much less obvious in the crossover arm of this study. But at least there's a fracture signal, quite a convincing one, coming out in this study. So let's have the next slide, please. And a question that all arises here, and that you may well be considering yourselves, of course, is what happened, what goes wrong with these long treatment periods on anti-resorptives? And the big fear, of course, is atypical femoral fractures and osteonecrosis. And Serge Ferrari has done some calculations on this, which I think are generally quite reassuring, looking at the skeletal benefit versus risk ratio. That's the skeletal benefit, i.e. fractures prevented, compared with the fractures that are attributed directly, these atypicals directly attributed to an anti-resorptive drug. And the ratio is really very high, 280 and 40 for ONJ, 280 for atypical femoral fracture. The implication there being that for every atypical femoral fracture you get on these anti-resorptives, you prevent about 280 more conventional type femoral fractures. Now, there's some assumptions built into these calculations, but I think as far as that goes, that's very reassuring. And the risk of a second fracture was significantly lower in the denosumab treated patients as well in those studies. Next, please. Now, what about this stuff, romosozumab? Now, this is another Amgen drug. You will all be aware of this stuff. I don't know how much it has been used in South Africa. It's exciting stuff. This is a sclerostin antagonist, and it is in studies in non-renal patients. It is the most effective way of putting bone on by some way. So it's extremely effective, substantially better than denosumab, which itself is better than the bisphosphonates. So the tolerability and efficacy of romosozumab in CKD seems to be similar to controls. Now, it's not licensed in CKD, but nevertheless, by the same token as the denosumab studies, the osteoporosis studies of romosozumab did end up including a significant number of patients with low GFR. No dose adjustment is required for patients with reduced GFR, and the hypocalcemia that we do see as a hazard with denosumab, particularly in patients with reduced GFR, is much less of an issue with Romo. It is a bit of an issue, but much less so. So next slide, please. So promising stuff. Now, it does work really well. I'm going to show you some slides showing just how well it works, but there's a potential sting in the tail here. And sclerostin is very importantly involved with regulating bone turnover. And sclerostin antagonists, sclerostin is an inhibitor of bone formation. So sclerostin antagonists, like romosozumab, would be expected to release more osteoblastic activity and increase bone formation. And all the evidence is that it does just that. So that's fine. The problem is that sclerostin is also widely distributed in the vasculature. And the action of romosozumab to inhibit sclerostin potentially would increase vascular calcification in smooth muscle cells, which are themselves, of course, subject to this propensity to transdifferentiate from standard vascular smooth muscle cells to a much more osteochondrogenic phenotype, which basically behaves like an osteoblast in the blood vessel wall. Not a good thing at all. And that could be augmented by sclerostin. So there's a concern there. The studies that have been done with romosozumab, one of them has shown a modest signal of concern in patients in respect of cardiovascular events. The bulk of evidence, though, does not show any signal. And I think the jury is probably back saying it's safe in that respect, but not quite. And people are playing very safe here, particularly in renal patients who already have an extremely high risk of vascular calcification. So, so there's some concern there. I think it's going to creep in gradually, but not yet. Next slide, please.
I think they said tomorrow they may meet. I'm not sure.
So here we have the results of Romo on BMD, two studies here, and you can see that along the top is the romosozumab compared with placebo, and you can see that there's a most dramatic augmentation of BMD, that's in green, compared with placebo across that study. So these are patients who've got reduced GFR, so that's three subsets of GFR there. Looking at the bottom, that's green and yellow. The yellow is alendronate, and the green is romosozumab, and you can see that the romosozumab, again, much better than the alendronate, which in turn is better than the placebo. So again, very impressive in terms of bone mineral density response in patients with a range of GFR levels. Next slide. And the picture with fracture is slightly less clear-cut, but it's still quite convincing. So on the left-hand side, the FRAME study, looking at fracture rate with placebo and romosozumab, and you can see that the romosozumab in green drops that right down compared with placebo. And on the right-hand side is the comparison with alendronate again, and you can see that romosozumab in green appears to be reducing fracture rate quite usefully compared to alendronate. So there's a lot of promise here, I think, and but some certain amount of stuff still to be done to unscramble the uncertainty. Next slide. So are we going to stimulate formation, or are we going to inhibit resorption, or both? Well, Romo does both, which we like very much. The biggest body of evidence is actually with the anti-resorptives, bisphosphonates and denosumab, both of which reduce fracture risk usefully over GFR down to CKD stage 3B and 4. And they do it to a similar degree to the fracture reduction seen in normals, and they seem to be quite safe in those patients as well. Next slide. So just to summarize the where we are here with these drugs and the safety. So up at the top here, we got the bisphosphonates. Their bioavailability is variable at the best of times, more so in patients with renal disease because of renal excretion. They reduce fracture rate in CKD, and that's very encouraging indeed. So, and I think I'm glad to see a progressive groundswell towards using those drugs much more in CKD. There's a theoretical argument for reducing dose in the CKD patients because of the increased bioavailability when the GFR is low. Denosumab, likewise, I think is a good drug in CKD. No need to change dose. Watch out for the hypocalcemia, which occurs in some patients with reduced GFR, can be very severe in a few. We can perhaps talk afterwards about how to avoid that happening. And also, of course, as you all know, with denosumab, when you stop it, there's a risk of a rebound accelerated bone loss, particularly from the axial skeleton. So you need to follow on with some sort of anti-resorptive. PTH analogs, little used in renal disease. I won't dwell on those further. Romosozumab, again, looking very promising, earlier stages. Again, almost certainly a similar offset effect to denosumab when you stop the drug with accelerated bone loss after that. So it needs to be followed by an anti-resorptive. So I think we can be quite encouraged by all that, actually. It's a moving, it's a work in progress, but I think things are going in the right direction. Next slide. So the intervention thresholds then. So this is a consensus statement that a group of us put together a few years ago. And we basically recommend that in CKD patients who have more than 50 with a fracture, we don't even think you need to have a BMD measurement. The fracture risk there is so high in those people, you might as well just get on and do it. In the absence of an osteoporotic fracture, then a T-score threshold of -2.5 is there's no reason to deviate from the standard WHO recommendation, although the adverse skeletal quality in the CKD patients may mean that a lower threshold is appropriate, but no one knows how much lower. And the FRAX country-specific intervention thresholds are broadly appropriate in the CKD patients. Next. So why is this not done more? Why are these patients as a group undertreated? And I think there are two broad issues. There's some professional issues and practical ones. The professional ones are just restrictions on license and guidelines. Another one is that a lot of the patients with osteoporosis will go and see bone doctors rather than nephrologists. And those ones who happen to have chronic kidney disease as well, I think the non-nephrologists often get concerned about the effect of low GFR, and I said they get spooked by low GFR. I think that happens a bit and is a barrier. And the flip side of that is that the nephrologists are broadly not very familiar with the new drugs. A lot of nephrologists are worried about denosumab and would be very concerned to use romosozumab. So I think they get spooked by the new drugs as well. So regardless of which sort of specialist the patient goes to, they may end up getting undertreated. And then the practical issues, the formulas may simply not make these drugs available in certain areas, and some of them are very expensive indeed, which is also going to get in the way. Next slide, please. And I just want to emphasize, that's right, that the absence of benefit, which is frequently the case, is not the same as presence of harm. And this has been a bugbear with osteoporosis trials in general, is that when patients have not been enrolled in the studies for certain various reasons, usually to try and keep the group homogeneous, then the failure to study them does not necessarily mean that the drugs are harmful there. I think that's a balance that it's a nuanced call in many drugs. It's a big issue for the pediatricians, of course, with all sorts of medications. But I think it applies here with the renal patients too. Next slide. And so what should we do now? This is basically, we're there now. Is fracture risk high? Well, in the CKD population, it is. We're going to ask ourselves, is this CKD, MBD, or osteoporosis, or is it both? And I should have added there that almost certainly there will be running in parallel accelerated cardiovascular disease with that as well. The osteoporosis drugs may be somewhat different in the CKD patient, but not as different as was thought in the past. So I think it's sensible to look at the traditional CKD MBD issues. So get the parathyroid hormone right, deal with the phosphate as best you can, and if they're vitamin D deficient, replenish with native vitamin D. And having done that, and I say then consider the osteoporosis, I think I should in fact say, and in parallel with that, consider the osteoporosis. CKD stage 1 to 5D generally treat as normals with a few caveats, and that is those are that the diagnostics are done as robust. Drug side effects seem to be similar to those in non-renal patients, and the risk-benefit, though, is slightly less favorable purely because of the uncertainty there. But the evidence that these drugs are bad in advanced CKD is not strong at all. And I think that's been, I hope that's gradually being dissipated, the concern there. Next slide, please. So just some light reading for you. Those of you who've got the energy to do that. These articles actually, I think, summarize reasonably well where we are in a slightly more detailed manner than I've done here. So I'll leave that one with you. I'll thank you for your attention, and very happy to take questions, of course.
Thanks very much, Prof, for that insight. And I think your point about these patients sort of seeing different specialists and almost sort of falling through the cracks is very, very relevant. I think that often happens. I know for myself as an endocrinologist, the moment that GFR is below 30, I'm very hesitant, usually just because exactly as you say, there's, just not a lot of evidence. But at the same time, quite rightly, we don't have a lot of evidence that we're going to be harming patients, and it's an extremely high risk population. And so we need to find ways to be treating them adequately. I'm just having a look at our questions here online, and as those come through, I just want to maybe ask one myself. So you commented, Prof, about the nephrologist not using the bone turnover markers. In our mind, sort of as endocrinologists, sort of when we're seeing a patient with advanced renal disease, that's often for us the starting point in kind of helping to decide which seems the most appropriate drug for the patient. And in the literature recently, I see there's been quite a shift away from sort of using PTH primarily to guide that, and sort of a mark to say we should be using bone-specific alkaline phosphatase, which is actually quite easily available, not all that expensive. And so maybe just your comment on, if you had to kind of spend some money on bone turnover markers, what would you be using?
Well, bone alkaline phosphatase is very appealing. It's in terms of predicting bone turnover, bone alk phos is roughly on a par with PTH. The two together are better than either, because they're coming from different directions. Bone alkaline phosphatase, of course, has no issue with renal excretion.
Exactly.
And again, I think it's a useful addition. It's not a very expensive test to do. Methodological issues to do with the assays have been problematic in the past, but much less so now. So I think it's a good.
Yeah. And then maybe just in terms of refining that fracture risk, and I take your point that bone mineral density, especially as GFR declines, becomes less reliable because we're dealing more with a qualitative issue. I mean, I don't think the literature is robust, but perhaps just, there's other qualitative diseases like type 2 diabetes and primary hyperparathyroidism, where we make use of trabecular bone score, which is also becoming more and more readily available on machines. Maybe your comment about the use of that in the renal patients?
Yeah, well, one of the difficulties with the renal patients, of course, is the very high prevalence of areas of sclerosis as well as porosis in the skeleton.
Yeah.
TBS, it can certainly be badly confounded by that. I don't think there's, personally, we haven't been particularly keen on TBS as a clinical tool in routine practice. I think there's more work to be done there, but I think the confounders may be to do with structural and regional differences.
Absolutely. Thanks for that, Prof. Okay, so some online questions coming through. First one, how do we prevent bone loss post-transplant? Should we continue calciferol after the procedure at lower doses? And at what stage would you introduce a bisphosphonate, I imagine, from a preventative point of view in patients on immunosuppressants, including steroids?
Yeah. Well, one of the big factors that's changed the game quite a lot is the use of steroids, how much steroid, and whether indeed any steroids at all. We did a number of studies over the last 20 years looking at bisphosphonates given at the time of transplantation to mitigate bone loss following transplantation, which in that era, when quite a lot of steroids was being used early on, and indeed modest doses long term, the bone loss was frightening, really frightening. I mean, people would be losing 10, 15, even 20% of their bone density over the first year. And you can almost completely eliminate that by giving bisphosphonate. We use permidronate mainly, giving an intravenous bisphosphonate at the time of the transplant. All very encouraging. The later studies we did, much larger studies, failed to show an effect on fracture. But by the time we were doing those later studies, the amount of steroid being given was much, much lower. And I think the big change there has been the reduction in steroid use. Having said that, though, I think it is a high-risk time, and you never know which patients are going to need quite a lot of steroids. I mean, a lot of our center, we don't use any following after the first 2 weeks, but every now and then you have a patient who's going to need a lot because of difficult rejection or a nasty underlying primary renal disease, the vasculitis or something like that. So I think we've got to be selective here. I think that the bisphosphonates seem to be so safe in that situation that I don't have a great concern about giving bisphosphonates to patients who may not actually need it.
Makes a lot of sense, and that bone loss happens quite quickly as well, so you don't have you don't want to miss the opportunity to intervene. You
may shut the stable door after the horse is bolted. If you do that, BMD at 6 months, a lot of damage can be done already.
Absolutely. Prof, the next question here is also related to cinacalcet. What about the role of cinacalcet post-transplant for persistent hyperparathyroidism? What's your comment there?
Well, it's definitely got a role. I mean, the question, I didn't actually answer the first question completely, the question of what do you do about PTH and vitamin D treatment. Post-transplant, as in pre-dialysis CKD and with dialysis CKD, if PTH is too high, you've broadly got two options to bring it down. Give a vitamin D compound or calcimimetic, and which you choose depends on one thing only, principally, and that is the prevailing level of serum calcium. So if calcium is fairly high and PTH is high, that is indicating that there's already a degree of autonomy of the parathyroid glands, and they will have significant hyperplasia, possibly nodular hyperplasia. That patient needs cinacalcet. Give them calcitriol, you'll bring the PTH down, but you'll push the calcium even higher, obviously. Not good.
Yeah.
Likewise, a patient whose PTH is too high, but whose calcium is sitting down in the lower part of the normal range, they don't need cinacalcet. That'll just make them worse. And they need a vitamin D compound. And you've got the very nice thing about those drugs is they move PTH in the same direction, but they move calcium in the opposite direction, in opposing direction. So you can really do what you like with the manipulating the dose of the two.
Exactly. And then a question I was hoping somebody would ask, how important is the bone biopsy? What would you view the hard indications to be to request one? And the person, unfortunately anonymous, has said, please say something about the challenges of interpreting the bone biopsies.
Well, that's the easy bit. Easy one to answer is in that it's difficult. You've got to find a pathologist who actually knows all about this and who's working in a lab that has the facilities to process the samples properly. So they don't grow on trees, as you're probably all aware. So the role of bone biopsy in nephrology, well, apart from being a research tool, back in the day, it was aluminium that was the key thing that we could identify very well on a bone biopsy and get a clear idea of what was going on there. This is not an issue now, or virtually never an issue. We don't give aluminium phosphate binders to these patients anymore, haven't done for decades. Aluminium contamination of water is very rare and should never happen. I'm sure it does happen occasionally when a system breaks down or some very naughty people decide they're going to cut corners and not clean up the water properly. But that's really it. I mean, I think someone who's got presumptive high turnover disease with elevated PTH, I can't see any point in doing a bone biopsy.
Yeah.
Someone who's got low turnover disease, or you think has, i.e. PTH is low, they're ticking over the serum calcium that's high normal. And the reason is that, of course, they've lost their skeletal buffer. And you just show them a calcium tablet and the calcium goes up even further because they can't buffer the stuff. Arguably a case there, but in most cases, you're just going to see adynamic bone disease. So I think it's in clinical practice, I think it's a very limited role now.
Yeah. And in that patient, Prof, who would present, with that biochemical constellation and sustain a fracture, if you had to choose one of the anabolic therapies in that setting, would you choose Romo above a PTH analog in that setting?
I think I would.
Yeah.
I mean, there's a Romo, the consensus and the license limits you to using it to 1 year. The same applied to PTH analogs until recently. And the PTH issue is being relaxed now, as I'm sure you know. But even so, the PTH is awkward stuff to use. Romo is much easier in practice. You're basically just firing it in, and it's more of a fire and forget for a while. I think the only worry is this cardiovascular business, and the practice has not borne out the theoretical concern yet, and hopefully it never will. And it is the best treatment there is in terms of efficacy. Yeah,
absolutely. So I asked the question with a little tongue in cheek because we don't have it yet in South Africa. I've been fortunate to have a couple of patients we've done a Section 21 for, and it is an amazing drug. So I'm hopeful that Aspen Pharmacare is listening and that we can get that access at some point for the right patients.
Yeah.
It is now 8 o'clock or just after that, so our hour is done. So, Prof, it leaves me just to say an incredibly big thank you. I think this is such a lovely forum for me as an endocrinologist to be able to discuss bone with nephrology colleagues. It feels like this is something we should be doing more frequently. And it's quite interesting in the literature to see sort of these multidisciplinary teams, around the world who kind of discuss these patients because they're interesting, they're complex. And often, we don't have guidelines that tell us what to do specifically, and we rely upon, people who are experienced in this field. So it's really very lovely. And perhaps, again, we could ask Aspen to keep this kind of forum going for us. And thank you so much to everybody who's given up their evening this evening to be here. Thank you for the questions, and thank you to you, Prof. Have a lovely evening.
Very nicely chaired. Thank you.